Thank you very much. Thank you, Jeff. Thank you, John, and thank you, Dr. Douglas, for inviting me. Some of this will be a little redundant to what John has mentioned, and I'll save some time by not elaborating too much on some of those duplications. So my job is to really discuss where we're going in the field of liver disease in terms of hepatitis treatment going forward. And as John mentioned, this is an exciting time in hepatology. And as I think the sole hepatologist here in this group, maybe not, it's my job to sort of tell you where we're going. And as treaters, the burden of treatment has really fallen on the hepatologist community to treat hepatitis C because of the complexity of the treatment of hepatitis C up to this time. This is now the third time you will have seen or discussed this slide. There are about 17,000 deaths when these two curves for HIV and hepatitis C overlapped in 2007. John pointed this out a little bit for the projected deaths. This is the projected number of cases of cirrhosis by age cohort going forward from this time, assuming we don't really change what we're currently doing. And by 2020, I think you can see that there will be almost 1 million cases of cirrhosis due to hepatitis C in the United States, many of those over the age of 50. The treatment of hepatitis C has been around since really the early 1990s, really the late 1980s, initially with interferon monotherapy and then interferon ribavirin combination therapy in the late 1990s. In the early 2000s, pegylated interferon and ribavirin combination therapy, which is where these curves are really based on. And the response to this pegylated interferon and ribavirin combination therapy really are the same as they are today with triple therapy using protease inhibitors. There are some people who have null responses. We see fewer of those. Actually, we don't see any of those with the protease inhibitors, but the partial responders, the rapid viral responders, early viral responders, and the most important thing, to remember here is that the sustained virologic response, and the definition of a sustained virologic response has evolved over the past several years. A year or two ago, the definition was no virus detected in the blood by a sensitive PCR technique 6 months, 24 weeks after stopping therapy. The FDA about a year ago suggested that 12 weeks after stopping therapy was as good as in terms of long-term outcome as waiting for a full 24 weeks. Now, the importance of that dropping of that 12 weeks to determine sustained viral response is very, very important because it allowed drug development to speed up. The development of new drugs did not have to wait for a full 24 weeks after stopping therapy to analyze their data for sustained viral response. And we now know that sustained viral response really equates to cure of hepatitis C. And I think as hepatologists and infectious disease experts, we've been reluctant to use the cure word. And I think in part to our disadvantage. And I think we've known that this was potentially equal to a cure for 15, 20 years. We know that patients who had a sustained viral response, who were followed out to 10 years after their sustained response, still remain, 98% of those patients still remain virus undetectable in their blood. When liver biopsies were done 5 and 10 years later, there was no virus detected in their liver. And more importantly, the liver histology has returned back towards normal. We used to think that cirrhosis was an irreversible process, that once you had cirrhosis, you always had cirrhosis. We now know from several studies that even cirrhosis is potentially reversible if one gets rid of the virus for a long period of time. It just takes years or decades for that cirrhosis and remodeling to occur. So I think we need to change our lexicon a little bit and link sustained viral response to cure. I think that's an important message. This was a paper published from several papers, but this graph is a paper published in December in JAMA, where there was an analysis of all-cause mortality and the effect of a sustained response on all-cause mortality. Now, previous studies have looked at mortality related to cirrhosis or mortality related to hepatocellular carcinoma, but those may miss patients who have cirrhosis but die in an automobile accident because of encephalopathy, or who have an infection the cause of death is called infection rather than due to spontaneous bacterial peritonitis, due to their ascites, due to their liver disease. So when you look at all-cause mortality, we see very significant improvements in mortality rate in those who have a sustained virologic response, and these curves continue to diverge at 10 years. The current therapy for hepatitis C, as John mentioned, is triple therapy: pegylated interferon, ribavirin, plus a third drug, and that third drug is a protease inhibitor. There were 2 approved in May of 2011. One was boceprevir, here abbreviated BOC, and the results from the phase 3 registration trials of boceprevir published in the New England Journal demonstrate an overall sustained viral response rate of around 66%. Now, and this is in genotype 1, and that's one thing that we haven't really discussed up to now, is that most of this data, and even looking at quality-adjusted life years, is really based around data on genotype 1, which represents about 60 to 70% of hepatitis C in the United States. The triple therapy is only used for genotype 1, not for genotypes 2 and 3, which represent about 25%, which are still treated with just pegylated interferon and ribavirin, which has a much lower cost. So here with boceprevir, the sustained virologic response rates are about 66%. Prior results with pegylated interferon and ribavirin, as you can see on the in the green bars, is around 40%. So a significant improvement in sustained viral response with the addition of a protease inhibitor. This is the data with telaprevir, the other protease inhibitor that's also used in combination with pegylated interferon and ribavirin, with sustained response rates of 72 to 79%, compared to a control arm with pegylated interferon and ribavirin of 46%. There is a difference between non-blacks and blacks, and all of these studies for many years have demonstrated this difference. We now know that probably the main reason for this difference is a difference in a genetic polymorphism on chromosome 19 called IL-28B, which is a gene that codes for an interferon lambda response, and there's a difference in the expression of that polymorphism in blacks versus non-blacks, and that probably accounts for most of this difference in sustained response rates. The problem with the current therapy with triple therapy are the side effects. We've known for years that pegylated interferon and ribavirin are associated with significant side effects: fatigue, leukopenia, thrombocytopenia, etc. But when we add telaprevir or boceprevir, we not only have the side effects of the pegylated interferon and ribavirin, but now we have the additional side effects of the telaprevir and boceprevir. So there's significant issues with rash and pruritus with telaprevir, significant issues with anemia and dysgeusia, which is bad metallic taste in the mouth, with boceprevir. Telaprevir has to be given with 20 grams of fat per each dose. There's a pill burden effect. Telaprevir has about 12 pills a day that are necessary, 4 pills every 8 hours. So there's a significant pill burden. And we know that adherence to this rigid regimen for 24 weeks in many patients, or sometimes 48 weeks, with a tail of pegylated interferon and ribavirin, is challenging and daunting. And every patient who has cirrhosis, it's recommended that whether they get boceprevir or telaprevir with their pegylated interferon, have to be treated for 48 weeks. So it's a full year of therapy. So there's cost issues, there's compliance issues, there's adherence issues, and there's significant issues of side effects with these current therapies. So as John pointed out, we've seen this tremendous increase. These bars on the left show the tremendous increase in sustained virologic response that we've seen over the past couple of decades, from 6% up to over 80% in some series, particularly with some of the newer agents. However, on the right, you'll see that if we don't change the number of patients treated, if we don't increase those individuals that are entering this pool, the our total treatment eradication will not really be significantly affected. So we have a lot of work to do. In the United States, there's about 4 million people with hepatitis C. Only about 25% have been diagnosed, and only about 11%, and these numbers vary a little bit, have actually been treated. So we need to get the bottom of this iceberg diagnosed. So the roles of the primary care provider, this is something that hopefully the birth cohort screening will encourage them to test without the stigma of asking about whether the patient had been a previous injection drug user or had more than 10 lifetime sexual partners, et cetera. If we can just say, well, because you're born between 1945 and 1965, you should be tested, and here's what I need to do for those who are identified. Counsel about alcohol, vaccinate for hepatitis A and B, and then refer to a provider who can deliver therapy. The annual medical cost for people with chronic hepatitis C infection from 2009 to 2028 by the source of insurance is demonstrated on this slide, and you can see that the cost will go up, but as John pointed out, the quality of life years, the cost effectiveness will still be quite good. I saw an abstract alert this morning from Clinical Infectious Disease about a new study on quality of life years expected from Andy Talal and the group at Cornell that's a little higher than the 35,000 that John pointed out, but still well below that 50,000 barrier that we think represents significant improvement. So in summary, hepatitis C is a growing problem. Treatments are rapidly improving, and that's my next part of this, is to discuss future therapies. We know that when the hepatitis C virus replicates, it replicates by having endogenous protease, endoprotease enzymes cleave the polyprotein, the 3,000 amino acid polyprotein of the hepatitis C virus, to release and free up the protease, serine NS3 protease enzyme, which then does downstream cleavage of the NS5A and NS5B. The NS5B is the RNA-dependent RNA polymerase, which is necessary for replication and production of new virus particles. So we have potentially, right now in our armamentarium, 4 classes of antiviral agents that are being developed. We have the protease, the NS3, NS4A protease inhibitors, which we've already have the telaprevir and boceprevir, and many new ones that are once a day, that are easier to take, that have better side effect profile. We also have NS5A inhibitors, and we have 2 NS5B inhibitors, nucleoside and non-nucleoside inhibitors of the RNA-dependent RNA polymerase. And some of those in active phase 2-3 development are listed on this slide. The number of protease inhibitors are impressive, and the potency, the antiviral potency of some of these inhibitors are truly impressive, with 3 and 4 log reductions with a single dose over the first 12 hours. Some of these are boosted with ritonavir, ABT450 by Abbott, now called AbbVie, and donaprevir by Roche Genentech, are boosted by ritonavir to improve their effectiveness and decrease their side effect profile. Most of these are relatively genotype specific for genotype 1, but some of the newer ones, particularly the Merck 5172, is pan-genotypic except for genotype 3A. And the goal eventually is to have these drugs be pan-genotypic, not just working for genotype 1, but for all genotypes. The nucleoside inhibitors, probably the one that's made the most news and has shown the most promise, is the Gilead drug GS7977, now called sofosbuvir. The non-nucleoside inhibitors have, correction, I must say that the nucleoside inhibitors have the advantage of a very high barrier for resistance. That resistance, there's only been one case of an S282 resistance found in a patient treated with sofosbuvir, and that has a very low activity of that resistant mutation. So these have a very high barrier to resistance and are good to combine with most other classes of drugs. The non-nucleoside inhibitors have a low barrier for resistance, but can be combined with other agents. And the NS5A inhibitors, particularly the BMS drug declatosphere, is probably furthest along in its development. This is a study that was presented at the European meetings last year, now in press, combining the nucleoside inhibitor sofosbuvir with the declatosphere by BMS, and it's an example of two companies working together, Gilead and BMS, to do this particular trial. Now, they haven't taken this forward. They're now going their sort of separate ways, but I think this shows what can be done when these companies do work together to develop combination therapy. More importantly, at the top bar in this, the sofosbuvir and declatosphere, which is from that study I just showed you, had a sustained virologic response of 100%. And it had a sustained viral response that was probably the highest. There were very few side effects seen in this combination therapy. There's no interferon or ribavirin. This is just two oral agents given for 24 weeks to this group of patients. Sofosbuvir plus ribavirin alone without declatosphere or without pegylated interferon, 88%. The combination from Abbott, ABT450, their 072, which is an NS5A inhibitor plus ribavirin, 82%. And Abbott's therapy with their non-nucleoside inhibitor 333 plus ribavirin plus ABT450, 95, and even 93% in previous interferon ribavirin null responders with only 12 weeks of therapy. So these are impressive results, and I think show us what the future potential is. And these are just some of the trials that are in phase 2 now. All of these companies have phase 3 clinical trials that are well underway for these agents. And the time course we anticipate is that in 2013, this year, the standard of care for genotypes 2 and 3 will still be pegylated interferon and ribavirin, abbreviated PR. For genotype 1, it will still be telaprevir and boceprevir with pegylated interferon and ribavirin. But late 2013, potentially next November, but more likely early 2014, we will have sofosbuvir and ribavirin for genotypes 2 and 3. That phase 3 clinical trial has been completed, and as that data is analyzed and an NDA submitted to the FDA, we anticipate that this will be approved by early 2014. For genotype 1, the drugs in the pipeline for genotype 1 that are in phase 3 trials include the addition of a newer protease inhibitor or sofosbuvir, the nucleoside inhibitor, but will still keep the backbone of pegylated interferon and ribavirin, because the combinations, the interferon-free combinations, will not be completed until 2014 timeframe, for approval in 2015, where for genotype 1, we anticipate that there will be a number of different combinations available for approval and linkage to care for patients with hepatitis C. Now, the advantage of this, as I see the future, is that over the next couple of years, we will still have a protease inhibitor plus pegylated interferon plus ribavirin as sort of the standard of care, with a diminishing number of patients treated by that modality as time goes on. And the protease inhibitors will likely change to be better, once a day, less toxic, more effective. Perhaps late 2014, early 2015, when we start to see all oral combinations, this will significantly expand the pool of potential patients to be treated. Many of the patients that are candidates for treatment now are being deferred therapy because of the toxicity associated with pegylated interferon and ribavirin. So as all oral interferon-free therapies are approved, it becomes easier to treat, less toxic, shorter duration of therapy, so more patients will be treated. And I think that still one of the encumbrances of therapy right now is still the number of treaters, and is that because the complexity of the treatment with pegylated interferon and ribavirin And as we get rid of the pegylated interferon and ribavirin, this therapy gets easier and more patients and more treaters can get on board. There may still be a role for quad therapy where we have 2 DAAs plus pegylated interferon and ribavirin for treatment failures. So the costs and impediments to current triple therapy are the travel to a center, time off work, the treatment costs, which are significant, and the complication rates. So the current treatment paradigm is identified hepatitis C patients, and as John pointed out, there's a failure of risk-based screening. Only 4% of patients are identified by risk-based screening, and we know we've only identified and diagnosed less than half the patients with hepatitis C, more like 25%. Of those cases referred for treatment, many have advanced disease. In our practice, almost 50% of the new patients we see with hepatitis C already have cirrhosis, but we're a specialty referral center. And then relatively few cases are treated because there are too few treaters. The treatment is labor intensive, and for a private practice or a non-university setting, it's actually money losing. The time involved for the reimbursement that's obtained, which is why many gastroenterologists in private practice have avoided treating patients with hepatitis C disease. So if we had an all-oral therapy, it would allow increased access to care. Expanded screening could be primary care or more easily, certainly GI, gastroenterology, and ID delivery. Less toxic drugs may mean less monitoring. Greater volume plus less monitoring may lower the overall cost of this therapy. So the ideal treatment paradigm that I would like to see, and I think this is a time when all of these forces come together and sort of the perfect storm that we might have an expanded identification of patients with hepatitis C who have been naive to treatment. This might be identified through an EMR-linked hepatitis C screening. At our institution, we're linking it to colon cancer screening so that patients who turn 50 when they get screened for colon cancer will be prodded to be screened for hepatitis C. Complex cases, known cirrhotics, prior treatment failures, complicated comorbidities could still be directed to specialist care. But of the identified patients who are otherwise naive to treatment, who are easily treated, could be treated by a primary care physician, a gastroenterologist, an ID physician, and if we had pangenotypic therapy that was all oral, where we don't have response-guided therapy, and it's 12 weeks, the screening tool could be fairly simple. It could be just a hepatitis C RNA measurement and a platelet count. We know that platelet count is a very good discriminator for who has cirrhosis and who doesn't. So if the platelet counts are greater than 150,000 and you're PCR positive, you could be initiated on therapy. We wouldn't get response-guided therapy. 12 weeks, you would get another test at the end of 12 weeks, and 12 weeks of follow-up. Those patients with the cure rates of 85, 90%, which we anticipate for many of these easily treated patients, those patients are done. The treatment failures and the complicated cases would then be referred to a specialist. So one could see, one could envision in the best of all worlds, maybe sometime by 2017, 2020, somewhere in that time frame, where if we had a pangenotypic, all-oral, 12-week therapy, that we could have a paradigm that looks somewhat like this. Thank you very much.